This is an all too common occurrence these days. I've got a mature, slightly intumescent cataract. I plan to do a phaco. So after doing my incisions, I go ahead, stain the capsule with trypan blue and fashion the rhexis with my cystotome. There's not much egress of fluid from, in fact there's hardly any egress of fluid from the puncture, so I think it's pretty safe to progress with my cystotome itself. I'm not planning a double rhexis or a spiral rhexis. So it's a little bit of an effort to control this rhexis, how it can be done. Probably Euthyrata forceps may make things easier, but anyway, managed with the cystotome itself. So once that's done, I just put in some HPMC. There is no need to do any hydrodissection in this case, and just push out some of the free cortex, put in the HPMC, take my sharp chopper in my left hand, my phaco tip in my right hand, aspirate some of the superficial cortex, and I plan to do probably the woodcutter's chopping technique, or a combination of the woodcutter's chopping technique and the quick chop, whatever you may call it. Most of these procedures are hybrid procedures. Principles remain the same. So that's the first chop. I rotate. I usually do this entire chopping maneuver at one go. Don't keep coming out of the AC. If you do that, your pupil may shut down on you, making the procedure even more difficult. So this is a relatively soft cataract, so I'm only at around 50% power, but I'm at 400 millimeters of mercury and vacuum, and around 40 ml AFR rate. I plan to get at least 4 segments in such cases before I actually start eating away these segments. And that's done, I think. And it's time to eat away these segments. So then going on for the next one, that looks like slightly big, so I chop it again. And eating these segments is no big deal. Chamber is very stable, followability is good. These small pieces, you can go and take them off. They usually get stuck near the paracenthesis, and yes, once you have completed all these segments, you will have a couple of segments near that paracenthesis. You need to go and take it out, and after that I use my bimanual to clean up the capsular bag of all cortical remnants. So I have cleaned almost one side completely. So just switch hands and clean that other bit as well. And now I am having my infusion cannula in one hand. So under infusion I am injecting this single piece hydrophobic IOL directly into the bag, and this is a technique that actually Dr. Neto has been encouraging me to do, and it's very simple. It cuts down time, and that's the end of the surgery. Thank you so much for watching.